I would like to share a little bit of information about the CSOHIMSS chapter and some of our upcoming events. First, as a reminder, the handouts, including the CEU form and the presentation slides from Mr. Kelly and these introductory slides, are all available within the handouts feature within the GoToWebinar app. We'll also be making these handouts available on the CSOHIMSS website under the Events and Education tab, and then you'll find them down under the past events. We'll also be posting a recording of this webinar to the CSOHIMSS YouTube channel, which you can find at youtube.com/user/CSOHIMSS videos. Now, if you would like to get in touch with CSOHIMSS chapter, our webpage is at csohio.himschapter.org. The email csohio.president@himschapter.org goes to me. My name is Scott Mash. I am the CSOHIMSS chapter president for this year. And the email csohio.info@himschapter.org goes to the rest of the board members. So by all means, if you would like to contact us, don't hesitate. If you have any questions about the chapter or any of our upcoming events, don't hesitate to email us. We're also pretty active on social media. We use our social media to share information about upcoming events, to maybe post an interesting article, or to also let you know about things going on at the HIMSS national level. We're available on Facebook, Twitter, and LinkedIn. Now, we would like to take some time to thank our sponsors, because without them, we really couldn't provide these educational opportunities, our conferences. We just couldn't do what we do without our sponsors. We would, like to especially thank our top-level sponsors, our premier-level sponsors, and those are Cover My Meds, which you can find at covermymeds.com, Expedient, again, you can find them at expedient.com, and Ahead, which you can find at thinkahead.com. Those are our premier-level sponsors. Our next level of sponsorship down is our elite-level sponsors, and again, thank you to our elite-level sponsors, who are Metasource, Blue Orange Compliance, Tech Systems, Obix Perinatal Data Systems, Data Gravity, Leidos, and Time Warner Business Class. Then our entry-level sponsorship, our partner-level sponsors, which are Encore, OHIMA, Virtual Officeware, and MMY Consulting. And again, thank you to all of our sponsors. If your organization is interested in becoming a sponsor, please contact me. We have, in addition to having our elite, premier, and partner-level sponsors, we have some other ways that we can get sponsors involved as well. But again, we do all we can to promote our sponsors at our events and between events, and we just, again, thank you very much to them. Now, I'd like to share some information about upcoming CSOHIMSS events. Our next big event that's coming up is what we call OHIT Day, which is the Ohio Healthcare Informatics Technology Day. We used to call this Advocacy Day. This is the 9th annual event that we're having. This will be Wednesday, April 27th at the Ohio State House Atrium. We don't have our registration open for this yet, but we're getting real close. What we do at this event is we have a particular topic that our goal is to educate our legislature, our representatives on that given topic. So we try to bring in some of our membership. We train them on the message that will be presented out to the legislature. Then we actually set up a meeting with your senator or your representative so that you can go meet with them and share that information with them. We always give some leave behinds. Great event. Rick Moore is our advocacy chair, and I'm telling you, he's one of the top in the nation, if not the top, as far as setting up these events. By all means, please plan on attending if at all possible. And this is a free event. Then our spring conference will be Friday, May 20th, and we are focusing on security. Security and HIPAA privacy security is a big topic right now. A lot of folks getting hacked and writing some great big checks in the healthcare industry, and we want to see what we can do about preventing that from happening in Ohio. So this is going to be our biggest conference we've ever held. Our goal is to hit 300 attendees and 30 sponsors. We have 3 educational tracks that will be going on. In addition to having, we have a morning and an afternoon keynote speaker, great keynote speakers. The registration is open. Please sign up. Please plan on attending. This is going to be a great event. Just amazing the speakers that we have for this. It's quite impressive. Special thank you to Ajay Sharma, who is our programs chair, who's really going above and beyond on this event. We do have some more Lunch and Learn webinars scheduled. The next one will be Wednesday, April 13th, and it's going to be the ABCs of Tiger and the virtual learning environment. This one will be presented by Taria Shaw of HIMSS and Victoria Wanjia Anderson from the University of Cincinnati. May 11th, Lisa Cannon, one of our board members, will be presenting on developing your brand, recruiting considerations, and other things to keep in mind as you transition into an HIT role. Really excited about this for our members. Our June, July, and August webinars right now, we don't have anything on the schedule yet, though I'll tell you I do have a stack of submissions I've got to get through. So, you know, if you are interested in presenting, by all means, let me know. We love to see our members, our members present and share their information, share what they know. You know, everybody is a specialist in something. They're an expert, and I just love to see more of our members take the opportunity to present and share their area of expertise. Now, also keep in mind, if you are presenting, you do get presentation points towards HIMSS member advancement towards senior and fellow membership status. So it's a great opportunity to just get some experience with presenting, as well as build your points towards senior and fellow membership status. We're also really excited about bringing the CAHIMSS and CPHIMS prep course and exam to Central Ohio. So what we're doing is on Thursday, April 14th from 8 to 3, we've scheduled a CAHIMSS exam. We're handling the registration for this, for the prep course. The cost for the prep course is $150. So 8 to 3, you'll have the prep course. And then from 3 to 5, if you want to sit for the CAHIMSS certification exam, you can register to do so. Now that registration is handled by HIMSS because they need to validate that that you've met the requirements for the CAHIMSS certification. The cost for the CAHIMSS certification exam is somewhere between $140 and $175, and the reason for that range is it's based on your membership type. There are only 25 seats available for the CAHIMSS exam. We've got room for for the prep course, but we have room for about 50 for the certification exam. You do not have to sign up for the prep course to take the exam. You can register for one and not the other. So, if you have any questions, give me a call or send me an email. Now, the CPHIMS review course and exam will be Friday. So, from 8 to 3, we'll have the CPHIMS exam. Cost is $150. Then, if you want to sit for the CPHIMS certification exam, again, it's from 3 to 5. The cost is a little higher. It's $270 to $300, again, depending on your membership type. And, again, you have to register separately for each of these. One thing we are going to do for folks that are members of CSOHIMSS, if you take the CAHIMSS prep course and the exam on the same day, and you are successfully pass the CAHIMSS exam, we're going to give you $25 of your money back. Just a little added incentive to sit for the CAHIMSS exam. For the CPHIMS exam, if you sign up for the review course and certification exam, and again are successful in passing the CPHIMS, we're going to return $50 to you. So the difference in price between the two, where we're kicking a little different back, is primarily because of the difference in cost of the certification exam. We're really excited about this. We still have room. If you're interested, I would recommend getting signed up now, because as we get a little closer, it's going to fill up quick. Again, 25 seats for the review course, and we have about 50 seats for the certification exam. We also like to share a little information on some of our partners that we work with. We do several events with OHIMA throughout the year, and they have their annual meeting and trade show coming up March 7th to 9th at Hilton. Great event. I've attended this numerous times myself. The registration link can be found below. So with that, I am now going to turn it over to Mr. Tim Kelly. Tim, you are unmuted, and I am now making you the presenter so that you can drive.
All right.
Good.
Scott, can you see my Can you see my screen okay, Scott?
Yes, sir. Screen showing up. Audio is great. The floor is yours.
Fantastic. Scott, thank you so much for the introduction, and folks, thank you so much for taking time to spend the lunch hour with me today. I got to give a quick shout out to Sonia Lemmerbrock. She's a project manager at Kettering Health Network. I've had the great pleasure of working with Sonia at Standard Register for a number of years. We sincerely miss her. We miss her too because we just changed our name this week. We're now Taylor Healthcare. We're part of Taylor Corporation. We were acquired by Taylor Corp last year, but our healthcare division, Taylor Healthcare, is still based right in Dayton, Ohio, and it's just a pleasure to be with you guys. Particularly, I know some of you were coming off of National HIMSS last week, and I know for those of you that are not recovering from that, you're probably recovering because you covered the fort for your colleagues while you had colleagues attending the National HIMSS conference. So thank you so much for making time in this hectic week to spend with me. What I hope to do here is to make it worth your while because in just less than 5 short months we're going to be confronted with something called the Notice Act, and it may catch a lot of folks by surprise, but not you folks, because we're going to go into great detail on that here today. A little bit of quick background first. What we're going to do in terms of objectives of this is we're going to look at the background that led up to this legislation, including just a quick overview of the 2 midnight rule, because that comes into play. We're going to look at what the impact of observation status is for both patients and for hospitals. We're going to look at some states that have been preemptive in taking a stab at very similar legislation and some things we can learn from that. We're going to look in great detail in terms of what exactly is required by the Notice Act. We're going to look at the ramifications in terms of compliance that it will mean for your respective organizations with this legislation. And, of course, we wouldn't be HIMSS if we didn't say let's figure out how to, potentially apply automation to some of this new legislation that's coming down the road. And we're going to consider some implications of this legislation, particularly implications that it may have for patients who leave against medical advice. And once again, what we could potentially do in terms of technology to assist in that area. With that said, some background. First of all, Medicare. This is what this legislation primarily applies to, and Medicare in the U.S. covers in excess of 50 million Americans. It's important to note when we think about Medicare patients, not all Medicare patients are over age 65. There are 2 parts of Medicare. This is probably either a review or a primer for some of you. There's Part A, which is what covers inpatient hospital admissions. Everyone who's covered by Medicare gets this automatically. And Part A covers your inpatient hospital stay, it covers stay at a skilled nursing facility, it covers home health, it covers hospice. Part B, for which a lot of Medicare patients pay a supplemental amount in order to be covered, that is the portion of Medicare that covers your physician office visits, it covers outpatient services, it covers rehab, it covers some mental health, and it covers other, lab and ancillary things. And it's important to note that it's the Part B that applies to an observation stay, an outpatient observation stay. This is probably the most discouraging slide that I'll share with you folks this afternoon. The 2 items that I'll call your attention to are the second and third horizontal bar graphs. The first one there indicates that half of Medicare patients have incomes of less than $24,000 a year, and half of Medicare beneficiaries have savings below $62,000 a year. And that speaks to, how challenging some of the costs associated with healthcare can be for our populations when in fact they don't have full coverage by Medicare. 2 midnight rule. I think some of you folks have probably heard about this. Quick overview. This was set out by CMS October of 2013. And in general, what it says is that patients are covered under Part A if they stay at hospitals in excess of 2 midnights. And for patients who are not within our hospitals for at least 2 midnights, Part A is generally not appropriate for those patients. And Medicare put this forth to try and create a little bit of clarity in terms of which patients should be treated as inpatients and which patients should be treated as outpatients. And quite frankly, they wanted to get their arms around some of the costs associated with short stay admissions. Now, we did see a little bit of movement on this past October, because this has been a violently contentious issue with hospitals. And unfortunately, I think a lot of hospitals were really hoping that CMS was going to repeal that. They did not. You might say that they're a little bit more collaborative with the 2 midnight rule than they've been in the past. They're allowing for a little bit more wiggle room in terms of case-by-case evaluation and some documentation flexibility in terms of when patients who are admitted for less than 2 midnights might be covered under Part A. Also, and I think this made a lot of hospitals happy, it basically moved enforcement of this rule from recovery order contractors, or the RACs, to quality improvement organizations. And there was a lot of concern on the part of hospitals that the recovery auditors were, they participated in any savings that they generated for Medicare. And so consequently, they may have had, a financial incentive to be tougher with things, and that has changed, and it remains to be seen whether this is going to be helpful to all of us or not. But we've had a tiny little bit of movement there in 2 midnight. In terms of ED visits, when we look at our ED population, it's instructive to consider this. We sort of have a bimodal distribution, and then we look at ED visits because these are the folks who are generally going to be, admitted for observation stays in hospitals. And of course, we see, a high portion of these patients being, under 6 years of age. They're the little kids that fall and hurt themselves and break things and require stitches. For those of us that have had, children of that age, we've been there, we've done that. We're always at the ED. And then, of course, the elderly. And these are the patients who present at the ED quite frequently, and these are, of course, the ones that are going to be applicable for this legislation. So, a minute about observation status. We've seen an uptick in observation admissions across U.S. hospitals. We've seen observation stays increase roughly 34%, and at the same time, inpatient stays have decreased. So we really are seeing a mix shift, a substitution of observation services for inpatient admissions. And why is that? Well, there are a number of drivers. First of all, 2 midnight, as we talked about. We've seen that be something that's been rather prescriptive in terms of saying exactly which patients should be considered observation outpatient stays. We've seen private insurers, some might say gleefully, follow suit and follow what Medicare did in terms of, once again, trying to minimize, their outlays and, thus avoid short, more expensive inpatient stays and to treat those as observation stays. They're the RAC program that I mentioned a moment ago. And, once again, I think a lot of hospitals were extremely conservative in how they categorize patients, because the last thing they wanted to have happen to them was be denied reimbursement because they had allegedly, incorrectly classified a patient. So that's weighed heavily on hospitals. And the final area, this is kind of contentious depending on whom you ask, but the hospital readmission reduction program, which, as I think many of us are familiar, this is where, we as hospitals can trigger a readmission penalty if we have inpatients who are discharged from our facilities and who readmit within 30 days. If that percentage of those patients who readmit is too high, we as hospitals this year can see up to 3% of our total Medicare reimbursement, held back or penalized to us by CMS. And the trick, if you will, with this is that outpatient readmissions. If that inpatient who readmits to the hospital is admitted as an outpatient, that does not trigger a readmission penalty. Now, there's people that have argued that this is either happening or not happening. A lot of the anecdotal evidence says that it may be going on to some extent out there, so that may too be a factor in why we're seeing increased use of observation status. So what's the impact of this upon our patients? Well, if you want to get a really great earful, the U.S. Senate Special Committee on Aging had a one-day hearing on this almost 2 years ago. You can listen to the audio and the video on this link. But in general, it was at times, really interesting testimony in terms of the impact on patients, primarily on the financial impact to patients. Basically, patients who are admitted as under observation status, which almost forces you to be an outpatient, means you are covered under Medicare Part B, and consequently you're going to pay a larger portion of those charges. Very importantly, and this is, that last bullet item is the one that really catches patients by surprise, is that under Part B, there is no coverage for what are quote-unquote called self-administered drugs, generally all the normal oral medications that patients are taking. So this is one of those things that is often a horrible surprise for patients. It's like, okay, I've been admitted to the hospital and I've got to get my, they're going to give me my usual blood pressure med that I take every day. They're going to give me my, cholesterol lowering drug I take every day. They're going to give me my blood thinning med that I take every day. All of my chronic meds I'm going to get, but I'm an inpatient. That's all covered under Medicare. No, not if you are Part B, an outpatient. That is none of that is covered, and this is where you hear the horror stories about $20 pills and all of that, and it's often a traumatic surprise for patients when they get the bill, when they don't appreciate the fact that they were covered under Part B as an outpatient. When you look at the costs, there are a couple of different statistics here, and it's important to look at who presented each one. The first was presented by AARP, the second by the Office of the Inspector General. Let's look at each. AARP did an analysis, and they found that roughly 10% of Medicare observation patients pay more out of pocket than they would have had they been admitted as inpatients, short stay inpatients. Meanwhile, the Office of the Inspector General looked at all, patients in aggregate and said, well, in general, outpatient stays are paying, roughly $300 less than comparable short stay admissions. So there's a sort of a general net benefit, although they acknowledge that for 6% of those beneficiaries, they definitely pay more than they would have for a similar short inpatient stay. So depending on how you look at these numbers, somewhere between 6 and 10% of Medicare beneficiaries who are admitted as short stay observation patients, they are going to pay more out of pocket than they would have had they been classified as inpatients under Medicare Part A. This is the area that's really not in dispute by anyone, and that is the fact that in order to be covered for under Medicare for subsequent coverage at a skilled nursing facility, a patient must have a 3-day hospital inpatient stay as a precondition. And if you're admitted as an outpatient, that's obviously not an inpatient stay. And as you can see from the analysis here, while there's not a relatively large percentage of patients who are impacted, the impact when it does hit a patient, as you can see there, $11,000, that is absolutely devastating in light of what I shared a little while ago in terms of the the financial wherewithal of Medicare patients in general. The other area where we tend to see an impact is on patient satisfaction scores. And this is the disconnect, of course, between what patients expect and what reality is. And when patients, understand, okay, you want to keep me for a while and look at me, so you're going to move me up to a bed in the hospital, and, okay, great, I'm in the hospital, I've got Medicare, I've been in the hospital before, I know most everything was covered because it's, I've got Medicare Part A, and, if patients don't fully understand what's happening, it can be a surprise, particularly when they get those bills and they find out, no, wait a minute, I was covered only under Medicare Part B, I was considered an outpatient, and that can have a significant negative impact on satisfaction scores. And all of us, of course, are concerned with our HCAP scores, so that can be a significant concern for us. Well, what has been the impact of all of this upon hospitals? First of all, I'd say that, we as hospitals have done really well in this area. We've invested in observation units. We've seen a growth in observation units, and that may be a good thing in terms of making care more efficient. As a matter of fact, we've found, some hospitals that do an especially good job with this can, in fact, deliver excellent quality of care less expensively and more efficiently in a outpatient observation setting than they can in an inpatient setting. So that's certainly good for many of us. We're also finding that I'd say a lot of us have preemptively done a good job trying to explain this intricacy to our patients. This is a nice example here of some, a handout prepared by the Florida Hospital Association, and others have done similar things. And, we're trying to help patients understand what it means to be an outpatient observation patient. Now, some states were preemptive in this area, and it's useful to look at those states. They tend to cluster here in the mid-Atlantic, southern New England states. The first to enact some legislation was the state of Maryland. This went into effect October 2013, and they said, hey, you've got to tell patients that are being admitted for observation that in fact they're outpatients, and you need to do that both orally and with written notice, and you've got to do some documentation associated with that. New York followed suit, and New York said, hey, it's important that you also make sure that patients, contact their insurance to see for those patients that have supplemental Medicare coverage, whether or not that will come into play and mitigate some of the, the potential cost-sharing aspects of that Part B observation admission. Connecticut similarly had similar legislation. Pennsylvania is very interesting. Pennsylvania actually put sunset language in their legislation, where they contemplated that if the federal government did get rid of that 3-day qualifying stay requirement for subsequent coverage in a skilled nursing facility, that this legislation, this requirement would go away from hospitals. It didn't happen, so it's still technically in place in Pennsylvania. And Virginia, I love what Virginia did. Virginia legislators put in a requirement for 14-point font in the documentation provided to patients. So Virginia legislators understand that a lot of our Medicare beneficiaries have less than perfect visual acuity, and consequently we don't want to give them documentation in mice type. We want to make sure the patients can read potentially what we're going to provide to them. So that's what a few states did. The federal government stepped in recently, and the Notice Act was signed by President Obama this past August 6th. It goes into effect this coming August 6th. And like great pieces of legislation, consider the HITECH Act, by example, there's an acronym involved here. I bet our congressmen spend more time coming up with the acronyms than they do with the legislation themselves. And this is a great acronym. NOTICE stands for Notice of Observation, Treatment, and Implication for Care Eligibility Act. Now, the nice thing I'll say about this legislation is, unlike the Affordable Care Act or something like that, This is not that ambiguous, and it's extremely short. So it's only a page and a half. It's only 488 words. There's a link to it there, and it's very nicely prescriptive. So I'd suggest that it's extremely understandable, and we can learn a lot from it. I'll go over it here in just a moment. A couple other things to note: this is not technically standalone legislation by itself. It is actually an amendment to the Social Security Act, so it's similar to other pieces of legislation we've seen, for example, the Patient Self-Determination Act, which are technically amendments to the Social Security Act. It also does contemplate language and rulemaking as determined by Secretary of Health and Human Services, which we have not seen yet. We may not see it until 60 days out, so we're still waiting for that, and I'll talk about that later. We do know plenty, though, and I'll go through all of this. All of this is from those 488 words. First of all, this is going to apply to all hospitals, including critical access hospitals. Nobody gets a pass on this requirement. It will apply to patients who receive observation services for more than 24 hours. So if it's less than that, they don't count. More than 24, we've got to make sure we do it, and we have to make sure we notify those patients of this at least 36 hours after that service begins. Very importantly, we must provide oral notification to our patients in addition to written notification. We can't do a HIPAA disclosure and slide a piece of paper across the table at patients and say, sign here. We actually have to have a discussion with them. Also, and this is where Congress really thought this through, the notification must be in plain language. So, once again, we can't give them, a bunch of legalese. We've got to, write some easy to understand verbiage for our patients to explain things to them. Also, Congress indicated that this must be in appropriate languages. So Congress clearly contemplates that not all Medicare beneficiaries may have English as their primary language. So we must be prepared for that. The written notification must explain to patients that they are an outpatient receiving observation services, and very specifically, they are not an inpatient. We have to tell them why they're being, admitted as an outpatient for observation. And we have to explain the implications, specifically the cost-sharing requirements, the Medicare Part A versus Medicare Part B differences. And we've got to explain, the really important thing, what it means in terms of subsequent eligibility for coverage in a skilled nursing facility. And then there's a little bit of the catch-all thing that Congress do in there, anything else that the Secretary determines to be appropriate. So you never know what other little hooks CMS could throw in there. Once again, I think this is pretty specific, so I don't anticipate having any real surprises with things. In terms of the documentation associated with this, it must be signed by the patient or by the patient's representative. Now, interestingly enough, Congress contemplated that patients may not sign this documentation that we are going to give to them. We may well have patients that are ticked off about, oh my goodness, I'm an outpatient, I'm not an inpatient, I'm not fully covered, and in which case Congress specifically states that the person who described all this to patients must document their name, their title, we've got to get their signature, and we have to date and time stamp it. So there is going to be documentation associated with this regardless of whether or not patients actually sign this material. Some implementation strategies for your respective organizations. 3 key things. Determine when you're going to do this, and I'd align it, and once again, you may be doing some of this, this disclosure today. I'd align it with an existing process, with a consent process, with an existing disclosure process, with a registration process, or some other, financial obligation process. It's always best if you mirror other things that you're currently doing with great repetition. Consider who's going to perform this notification? Once again, this has the very specific, oral explanation associated with it. So it may be lengthy for some patients, and to that end, you may contemplate training and certification of the individuals who will be certified to potentially do this. Consider how you're going to perform this process. Great practices say to involve family members, to potentially do it over a protracted period of time, and to employ concepts such as teach back. That means you don't ask a patient do you understand everything I just told you, and you get the nod. You ask patients, tell me in your own words, the fact that you were being admitted as an observation outpatient, what does that mean for you if ultimately you're going to require care at a skilled nursing facility? So that's how we quantifiably understand that patients comprehend everything that we've disclosed to them. In terms of documentation, once again, we wouldn't be a HIMSS chapter if we weren't saying, consider automating this process. And probably the biggest thing, and we don't know this until we see the actual final regs from CMS, but my guess is there'll be some sort of little penalty hook associated with this. I can't say, we haven't seen it yet, but it would not surprise me in the least if they're not going to pay for things unless we have this documentation complete for patients. So let's make sure we do a pristine job of documenting this, this process for each and every patient. And automation is the best way to do that. It will standardize what could be, a complex process across providers. It will protect us against having any errors and omissions in any documentation that we're doing, and of course, it'll nicely allow us to to memorialize this information. The best systems out there are also going to ensure that we've always got the most current version of documents in front of patients. It will put documentation that supports multiple languages instantly at our fingertips. And the best systems out there will allow for business rules. For example, a drop-down list where you can, select the reason as to why that particular patient is being admitted for observation status. Once again, the best systems, if we do this really well and we do it electronically, we're going to collect digitized signatures. Once again, we have to collect the patient's or a patient's representative signature or the provider's signature. So we're going to have to collect signatures. The best systems will do that. And those same systems will automatically date and time stamp those signatures when we get them. The best systems, once again, will allow us to push this information out to the patient portal. We can email this information to patients, and I always recommend, no matter what you do, print a copy and give it to your patients as well. Do hang on to a piece of paper. But that said, well, once again, I advocate that we do this all electronically, that we eliminate scanning, that we make it paperless, and that way we have systems that automatically push this into our EHR or into our document management systems. In terms of content, we've got to wait and see. CMS may well supply us with some language. Good news is Health and Human Services has already developed some pretty nice information. There's a link to it on here, as well as links to some information that was developed by the Illinois Hospital Association that I like, as well as the Florida Hospital Association that I think I might have shown previously. And of course, there are providers like like ourselves, telehealth care, that do a really good job with procedure-specific consent. So we've got experience developing easy to understand content for patients. Potential ramifications of this. This is something that we see today when we do explain this, an observation admission to patients. This often happens in the emergency department where we've got a patient, we just want to hang on to them for a little while longer. We want to admit them for observation, and we explain to them, well, it's not an inpatient stay. It's, it's an outpatient stay, and it's only covered under Medicare Part B. And at that point, you have some patients that say, sorry, I can't afford that. I'm going, doc. And they leave against medical advice. So it's possible that this will have, we're all sort of wondering, will this accelerate this situation? I would suggest that this is a time when we look really closely at what types of patient follow-up programs we have in place, particularly for the older patients who are discharged from our emergency departments. If we're doing callbacks today, let's make sure we expand those. And if we don't have that in place, once again, we wouldn't be HIMSS if we didn't talk about automation. Look at how you can automate that process. The best systems out there will reach out to patients via text or email, and we'll check on them to make sure that 24 to 48 hours after we've discharged them, that they have not taken a turn for the worse, that they are, progressing as we expected. The best systems will ensure that those patients are, pursuing their follow-up appointments, that we've helped them navigate, that they've, gotten their medications, and that they have no questions about their discharge instructions. And the best systems, once again, if anything has fallen off the rails, the best systems out there will alert, us providers that patients need supplemental assistance. Just by way of an example, this is a great organization. This is Edward Hospital, just outside of Chicago. But they implemented an automated patient follow-up program for all of their ED patients, and they found that total admissions from their ED dropped about 20%, and very specifically their observation admissions from their ED fell by 1/2. And the reason was their ED physicians were, and this is, by the way, this is a large facility, 70,000 annual ED visits. Their ED physicians, knowing that every patient was going to be contacted, and this system they use first tries to reach patients by text or email, then by phone, and knowing that all of those patients would attempt to be contacted, those physicians were a little more comfortable allowing those patients, those gray area patients who were right on the bubble, who wanted to go home anyway, those physicians were comfortable allowing those patients to go home. So, looking ahead, first of all, let's all watch for final CMS guidance. I just checked this morning, nothing yet from CMS. So all we have is the 488 words to work with. But as I've shared with you, it's pretty prescriptive. I think we know exactly what's coming. There might be the slightest little tweak by CMS, so we just got to watch. We may not know till 60 days out. That said, start now. It's important to recall, too, what this legislation does and does not do. It does not fix the two-midnight quandary, unfortunately. Really unfortunately, I'm going to editorialize here, it doesn't fix the 3-day inpatient requirement for coverage in a skilled nursing facility. I think Congress missed it here. I think Congress could have so easily have said, observation stays, count toward that coverage, and they didn't. So that's what makes this legislation partially so important. And what it does do for us, though, is it is going to, force us, encourage us to do a better job of informing and educating patients. And on the upside there, hopefully we may see an uptick in our satisfaction scores as, patients who are not surprised and better understand things, up front, hopefully should, enjoy a better experience, regardless of what things mean financially for them. Some unknowns with this. It remains to be seen if this is going to, have any mix shift with observation admissions. Now that we're better explaining things to patients, are we more likely to, treat them as observation admissions, as opposed to trying to, somehow negotiate them into a short inpatient stay. Hopefully, it may have a positive impact on collections. If we better explain to patients their financial obligations up front, are we going to see, an improvement in terms of collections? And on the potential downside of things, is this going to result in an increase in patients who leave against medical advice? If patients do understand their financial obligations, and while we eliminate that surprise, are we now more likely to see patients elect not to stay when we want to keep them for observation? What to do today? A few things. First of all, revisit your observation service lines. Have them ready. They're probably really good right now, but just give them a once-over. I would suggest that you look at your observation stay notification program. Chances are you're doing something ad hoc today, and it's probably pretty good what you're doing. I would suggest that you formalize it. And if you don't have anything formally in place, please implement it. And I would suggest that you follow exactly what we discussed today. It's pretty clear what's going to be required by the Notice Act. I don't believe that any final tweaks by CMS will be dramatic, and certainly implementing something today will get that in place, and it will be certainly very good for our patients. There's really nothing to wait for. Also, I would suggest that we all really pay close attention to our patient follow-up programs to make sure that we have things in place for our discharged ED patients to check on all of them. With that said, I'll take some questions. I will mention if anybody wants to reach me, there's my email. I have written a little, kind of a nice tight little summary of this if you want to share something that's kind of nice and concise. It was published by Patient Safety and Quality Healthcare, and I sort of mentioned a couple general ways of documenting things and following up with patients, and needless to say, at Taylor Healthcare we have some experience in that area, and there are a couple links to those solutions. And with that said, Scott, do we have any questions?
Yeah, we have a couple. Just as a quick reminder to folks, if you do have a question, please enter it into the integrated questions feature within GoToWebinar. If you can't find that, just put it in the chat. We'll answer it as well. But we have a couple here. First one is, has there been any indication that the private insurance payers will take a Me Too stance and require the same from hospitals as Medicare is with regards to the Notice Act?
Nothing yet, but I would, if I had, as a betting man, I'd bet they will precisely follow exactly what Medicare does. They've done that with 2 midnight, and I would expect that they will follow in this area as well. I try not to be cynical, but anything that is efficient, if you will, in terms of Medicare reimbursement is very quickly adopted by private payers. So I'd expect that.
And the next question kind of follows along that cynical comment. So it seems that the real intent of the Notice Act is to shift more costs back for short stays back to the patient, and even to discourage a hospital from utilizing short stays for a patient, and instead shifting care back to the primary care physicians or other providers of care. Is this correct, or what's your take?
My take isn't, and this is purely opinion here, folks. And I hope nobody from the government's on the line listening. I don't think that the intent of any of this, particularly when you listen to the Senate testimony, was to move things one way or the other. I think that's been accomplished a little bit by 2 midnight, and if anything, we saw a little bit of a loosening in that area. I think that the challenge there, the underlying challenge with a short stay observation admission existed. It's covered under Part A and Part B and not Part A, and rather than, I hate to say it, rather than fixing some of that, and as I sort of pointed out, the easiest, simplest thing to fix would have been the coverage requirement for subsequent coverage in SNF. I think instead of doing anything that either cost more money or even saved money, I think what Congress did is, let's just do a better job of explaining things to patients. I think that was, we threw Congress, an underhand softball pitch, and they whiffed at it. They just gave us, education. So I still think, as I sort of said, that's still a good thing. It hasn't solved any of the underlying problems, other than it is going to make for more informed patients. And let's face it, our elderly patients sometimes do struggle with some of these concepts, and if we collectively haven't been doing as good a job as we could with with educating them, it's not coming from CMS, it's now on our shoulders. So that's sort of my take on it.
Okay. Next question is, would a patient who is in a short stay bed in observation status that is then discharged and goes home, but then later returns to the hospital and is admitted, count as a readmission? And I'm sure this question kind of leads into the, some hospitals are receiving readmission penalties. There's a huge focus on readmissions right now.
Yeah, thankfully, no. The readmission penalties apply to inpatients. And right now, oh my goodness, I used to know this by heart, and they've just expanded it. It was inpatients who were admitted for congestive heart failure, for pneumonia, for acute MI, and there's one other thing which I'm drawing a blank on. But if you take a look at it, they're inpatients who have been admitted as inpatients for certain conditions. Those are the conditions that we get penalized against. Thankfully, they don't look, we sort of look at things in broad brush, all discharged inpatients, but it's only for certain conditions, but CMS keeps expanding those. And those patients who readmit are the ones where we are subject to the readmission penalty, which of course was a component of the Affordable Care Act. So if we've had an observation admission patient who, who's there for observation, and we let them go, and they come back, that is generally, not, there should be no penalties associated with that. To the best of my knowledge, you never know what interesting things private payers may have involved, but as far as CMS, I don't believe there's any negative impact from a CMS perspective.
Well, that is our last question. And first, I'd like to thank all of our attendees. Thank you so much for attending our session today. Please look at the CSOHIMSS website and register for some of our future Lunch and Learn webinars. And again, we're going to be adding some more. This is something that we want to continue into the foreseeable future. And Tim, thank you so much for presenting today. Great topic, great presentation, and thank you so much for sharing this information with the CSOHIMSS members.
Thank you, Scott, and thank you all you folks who attended. I appreciate it.
And with that, we'll go ahead and end the webinar. Again, if you guys have any questions for Tim, please feel free to contact him directly. If you have questions about the CSOHIMSS chapter, send me an email, give me a call, and we'll make sure we get you the information needed. So thank you so much, and we'll see y'all later.